I think that that's really the message and the piece that I would like to say.
Dr. Thompson.
Okay, in terms of the needs assessment, we've actually done focus groups and interviews with physicians as well as with women with breast cancer. And the whole idea was to find out from the women what their concerns were in terms of breast cancer treatment, and then to find out from the physicians what they thought they were communicating and what they thought they were doing. So if you're doing a needs assessment, it's more complicated than simply interviewing, as much as I would like it to be simpler, it's more complicated than just interviewing one group of constituents. You have to interview a variety of groups of constituents so that you know what everybody is thinking and you can find the common ground. And that's what your needs assessment ends up with, is the common ground.
Well, there's somebody there. Yeah, please.
Yes, I'm Rosemary Clement. I'm a certified breast care navigator. And I'd like to address this to Dr. Winchester. When you talk about certification, you included having a geneticist. But even in the U.S., we have just over 300 master's prepared geneticists. We have a real lack of them. 55 of them work for Myriad. So it isn't even that realistic for us in my hospital to even hire a geneticist. We're a small hospital. We'd like to become a breast center. So when you look at this even expanding to low and middle resource countries, what is the reality of getting geneticists on the ground? I do have the BRCA2 defect. I know how important this is. It does affect 8 to 10% of the American population of women who are diagnosed with breast cancer. Lisa Newman is also doing research on the triple negative patients, and hopefully that will lead to more genetic testing for those women. So it is a concern that is growing. And I really don't know, other than having advanced practice nurses work also in the function of doing a three-generation pedigree, I don't know of any other answer to address this problem.
Well, you've identified a gap. You've identified a national need for more trained genetic counselors. And we believe that setting a standard helps drive fulfillment of and attention to that need. Now, is that going to happen in a year or two? Probably not. That's why we do allow for referral in centers where there is no trained medical geneticist that you can refer the patient for that service. And so you're still meeting the standards, even though you're not providing them yourself.
Just for instance, in the Charlotte, North Carolina area, we had 2 trained master's prepared geneticists. One went out on maternity leave. The other one has a 6-week waiting period.
That's a problem.
It is.
Well, that's quite comparable to not having a medical oncologist or radiation oncologist in some of the developing country area, and we need to find out how best somebody else can pitch in and serve the need. Yeah.
What we don't like to see out in the community in medical genetics is a direct referral from a physician who has no formal training in genetics to have a blood test for BRCA1 too. I think that's one thing we'd like to try and change. We think that's happening. I don't know how prevalent it is, but I don't think that's optimal.
True. Yeah.
Dr. Samir Amoudi from Saudi Arabia. Dr. Thompson, thank you very much for your presentation. It touched my feelings as a doctor and as a breast cancer survivor, as an advocate as well. And a lot of the things that you've mentioned, I felt it, and I went through the same problems as a woman and as a patient. I think that one of the areas that we did not study enough in I don't know, maybe in the United States it's different culture, but we need a lot of studies in this area, particularly in the relation between the healthcare providers and the woman, the communication skills, and it should be included in the curriculum of the medical schools. This is one thing. But what's amazing is when you've said that you could do the qualitative measures or the studies on the healthcare policy makers. Have you tried this here? How did that go on?
We tried that in a project not related to breast cancer, but related to of all things pesticide exposure. And we interviewed, I believe it was some 20 policymakers in terms of what they thought, and we ended up with finding a lot of conflict between the policymakers. And so we did a very careful analysis to try to find the common ground. And there was a middle ground, and everybody agreed with it, and those were the people that went forward then in terms of that project. So it can be done.
Just one more.
Helge Stalsberg, I'm a pathologist. I just wanted to make a comment on the importance of creating awareness and demand on the receiving side. Referring to the picture of the broken bridge that Peggy Porter showed us, I believe it's important that that bridge is built from both sides. Referring to our pathology project in Ghana, which has developed very well, that would never have occurred if the hospital hadn't taken the initiative to go out and ask for help. It wouldn't have happened if the hospital's director, Dr. Anthony Nsiasare, hadn't recognized the importance of pathology and decided to do something about it. I was told that his predecessor didn't believe in cancer, at least not in cancer treatment, and thought they would all die. So there was low priority for pathology in budgeting, and he thus contributed to the decline and final total disruption of that activity. And also the fact that the receiving hospital contributed substantially by acquiring new basic equipment for the histology laboratory, and also by some money to pay for the training of pathologists in Norway, although that covered not more than about 20% of their salary. That made it easier to get funds from other side, among them Norwegian governmental money. So I think the bridge, it's important that it's built also from the receiving side by creating awareness of the problem